interact with you during this meeting. So please use the chat box to say anything that you want to say to us. If you want to say it only to the panelists, you click that, but you have an option to say your whatever you want to say on the chat box to all panelists and attendees so everybody can see what you are saying. And please place all your questions on the Q&A chat box, and we are going to do our best to answer during this meeting all of your questions. So follow us on social media. We are very happy to have amazing number of people already following us and interacting with us on social media. Soon we are going to have our website. This is something that we are going to announce in the next couple of weeks, and we are very happy and very proud about that. And if you want to watch any of the previous meetings, you can go to our YouTube channel. Then you're going to be able to see everything that we already did. And we have this feedback survey. This is very important that you fill that for us because we want to make things even better all the time for you. I'm going to place all the links of all the meetings and of the feedback survey on our chat box now, so you are able to have the link. So tomorrow we are going to have Dr. Anderson talking about hypoplastic left heart syndrome, morphology of it. It's going to be amazing. Please join us. And all his sessions has been very, very useful, and we are very happy and proud to have him with us. And on tomorrow as well, the entire day, we are working in collaboration with University of Minnesota in one entire day talking about heart failure in patients with congenital heart disease. It's going to be a very interesting symposium. If you feel like, if you're interested, please join it as well. Next Thursday, we are going to have an amazing webinar. We are very happy and very excited about it. It's going to be the second part of the surgical webinar. And we have as a keynote speaker, Dr. Nikaido. And we are going to talk about a lot of other surgeries and with the speakers from all over the world. And so we are very happy, and please join us next Thursday. And I'm very proud and excited to announce that finally Gil is going to have a series to talk about his deep thoughts on a lot of interesting topics on our field. And so the first one, he's going to talk about TGA and arterial switch operation from birth to adulthood. Is going to be a very interactive session. So he's the only speaker, and he's going to do this one Friday a month at 11 a.m. or 5 p.m. on European time. So September is going to be about TGA. Gil?
Is that my cue? That's my cue?
Yes.
Okay, thanks. I actually was just texting to Darren like how cool this is. We see so many people from all over the country, and it's been such a bright spot in the midst of this pandemic to be able to get together experts from around the world on one screen and able to have interactive sessions. Two of my very closest friends helped organize the science for this webinar today and will be taking over for much of what's going on through the rest of the webinar. First, I'd like to introduce Melissa Jones, who on my screen is in the bottom left corner, but I don't know where she is on yours. Melissa is an advanced practice nurse in our cardiac intensive care unit at Children's National. She's also just been elected as a member at large of the Cardiac Neurodevelopmental Outcome Collaborative and is the incoming president of the Pediatric Cardiac Intensive Care Society. Clearly an underachiever. And also another good friend of mine who just left Children's National and is now the director of cardiac critical care medicine and patient and safety quality at the Johns Hopkins Blaylock Taussig Thomas Heart Institute. Did I get that right, Darren? We miss you very much at Children's, but what's great about the webinars is we can stay in touch. And I'm going to turn the moderating and the rest over to Darren and Melissa. Darren.
Great, thanks, Gil, and thanks to the Congenital Heart Academy for this opportunity. It's wonderful to be able to do this with such an amazing foundation that Gil and Sasha and Grace have developed here and partner with PCICS to really bring some incredible educational opportunities to the world. And then most importantly, to have it available to everybody on YouTube. I just want to say thanks to the three of you for doing this. It's an unbelievable resource and asset to all of us, and really one of the silver linings of this whole COVID experience. Well, without further ado, what we were really trying to hope to do today is provide an opportunity for folks to learn in a way that is not only novel, but also essentially at zero cost to them, ways to improve patient care and outcomes that have been established by leaders in the field and have years of data really and experience to support the practice. And so without any further ado, I'd like to kick off the first part of this session, which we called Improving Care at Zero, essentially Improving Care at Zero Cost, with introducing to you Allan Goldman and Charlotte Tivy-Jones, who are going to start the conversation about a handoff process from the OR to the cardiac intensive care unit. Dr. Goldman has been a cardiac intensivist at Great Ormond Street Hospital in London since 1998, and he's currently the chief of the Body, Bones, and Mind Directorate and Group Director of the Pharmacy, Labs, and Therapies at Great Ormond Street. He's had a longstanding interest in mechanical support, human factors, and safety. Charlotte is a nurse working in the cardiac intensive care unit at Great Ormond Street for the last 18 years and recently completed her advanced practice nurse practitioner degree in 2017 and is in the process of expanding that practice there, where she has already trained 4 nurses and are currently growing their practice. Allan and Charlotte, thank you so much for joining us today. We look forward to hearing from both of you. Allan, I think you're muted.
Darren, thank you so much for having us, and Gil for this amazing event and your kind introductions. So we'll just share our screen here. Okay, so we'll kick off straight away. As Darren said, we work at Great Ormond Street Hospital. This was our cardiac team at a leaving do not long ago. Not everybody, but it shows that we're getting bigger and bigger teams, more specialized. And so the interfaces between people in these teams is becoming more and more important. Okay. How we're going to approach this talk is I'm going to just talk about how we got into the handover and studied it and give a brief basis for the history of it and where we set out. And then Charlotte will give an update of how things have evolved and how we've had to change with technology and the challenges therein. So our story really goes back to the early switch days. Professor Delaval was our head of cardiac surgery. And we had a cluster of patients who died sadly after the switch operation. And Mark then got involved in introducing Jim Reason, who was the guru of human factors, and Jane Carthy. And they studied what were the human factors involved in outcomes after the arterial switch operation. And one of the critical interfaces that came to light was this interface between the theater and the ICU team. Grand Prix and the changing, the team training and heading off to Maranello wasn't a bad session. We came back as a team and we redesigned our handover and we tried to simplify it. And the first part of the handover that we introduced was for the theatre team would send up some information to the IC on a sheet of paper, roughly when the patient was coming and what kind of support they were on. And then when the patient came back to theatre, we kind of divided into 3 very distinct phases. We would transfer the technology in silence unless there was a safety issue. At the end of that, the team would huddle around the bed and we would hand over the information in a very systematic format using an aid memoir sheet I'll show you. And then we introduced, we had an anticipated recovery. And so the anaesthetists had a sheet like this and the ICU a receiving sheet. And the anaesthetist we put in charge of the process, as was shown in the video, as they had the best overview. And we called this at the time an aid memoir. This was pre-WHO checklist because it was felt we would insult people's intelligence if we used an actual checklist at that time. And so the anaesthetist would hand over their side of what had happened pre-op and during the operation. The surgeon would then hand over the aspects of the technical aspects of the operation, and we would then decide a plan of effectively wake and wean, watch for a bit, worried about the patient, or an ECMO standby. And we then studied that with our human factors expert, and we showed that we could reduce the number of non-technical errors by about 40% and also reduced error cascading. Interestingly, when I was visiting Boston with Peter Lawson at a point, he had showed that Boston were using a similar thing, but it introduced a readback from the receiving team at the end of the handover. And I think that is, again, it adds to the level of this handover. And I think to people receiving the handover, if they know they got to read back, the level of concentration and that really adds to that. So you may say, does this really matter? And I would say, yes, these little things really do matter, and they do make a big difference. As illustrated in this very nice study by the American Royal College of Surgeons, where they asked trainees to hand over information as a course of 5 handovers, with handover retained 33% on 1 handover to only 2.5% as you do it to 5. So these things do matter. And recently we had a sort of serious incident involving handover of a patient who wasn't cardiac from theaters to the ICU, which landed up in the coroner's case, where these things do make a difference. So that really gives you a history of how we got into this and how we evolved our handover and tried to simplify it. And what I'm now going to do is hand over to Charlotte, who will tell you of how we've evolved this over the next 10 to 15 years and how we've adapted to advancing technologies.
That's great. Thanks, Alan. Hi, everyone. So as you can see, we do a kind of warm-up routine, exactly like the picture. That's how we all look on a Friday, where we have our surgical pump meeting and we discuss the cases for the next week. We then do, on a daily basis, after our ward rounds on CICU, we have a briefing, which involves the senior nursing team on that day, and then the medical team as well, which then allows us to do a bit of hopefully teaching if we have time, and some case-based discussions around whichever procedures will be done that day. At this point in time, we also allocate which medical staff or ANP, ACP will be allocated to that patient, so we can identify roles quite early on, which helps the planning of the patients and things as well. And then moving on to our new technologies, thanks Al. So this, we've recently gone to Epic. We were using a different operating system before. So we had CareView before. So over the last couple of years, we've moved on to Epic. And we've also tried to adapt how we do the handover with our new Epic system. So we have to move with the times. There's been some good aspects, obviously, and but also some quite challenging ones. And the key has been just for us to adapt and try and see what works for our team. So we have tried to go paper-free. One of the problems with going paper-free was that we lost the nice visual tool that we had originally with the handover that Alan had done all the work from the Formula One. This gave us a key idea of who would be doing what during the handover. So it's been really important for those of us who have been there for a long time on the CICU and saw the implementation of this project as well. We've had to kind of keep driving it forwards and keep embedding it into the practice, but obviously adapting as we go, ensuring that bad habits don't sort of filter in and things don't get lost in translation. We've also got quite a high staff turnover, so education of all our staff has been key into keeping this going. So it's really about future-proofing our handovers and identifying and keeping those key players and moving forwards with education. But one of the good things, as you can see here, is the secure chat system that we have with Epic. This allows us to communicate with the theatre team directly whilst the patient is in theatre. Our ward admin will send a message to the theatre team in the morning, which allows the team to know who the senior nursing team is on the ward, and then which actual bed space the patient will come back to. So when they come back to the ward, they don't need to do a little dance, and they can just bring the patient right to the right place. It works really well. The anaesthetist will then let us know any specifics of the patient details, any issues that they've had in theatre, and any ventilation settings and things like that, so we can get the bed space fully prepared for when the patient and the team arrive. I think it was just, I was saying to Allan this morning, even last week we had messages from the anaesthetist about a patient. I think he'd had, it was his third redo surgery, and he was very difficult for IV access, as you can imagine. So that allowed us to plan for what equipment we would need for his return from theatre. And also any patients with difficult airways, we can then get all our difficult airway equipment at the bedside in case of any untoward events. And also it's really good, our medical team also, if they know there's a problem in theatres with a patient, they can then go down to theatre and speak directly to the team and get really good communication and face-to-face communication, so they can be updated with what's going on. So this is, everyone looks really happy and laid back in this. This is exactly how it is in real life. The patient arrives from theatre and the team knows where to go, which is really helpful. We transfer the technology first. Obviously there can be issues with technology, but most of the team's pretty good at troubleshooting. We do all our safety checks, and then we do our handover huddle. This is usually led by our anaesthetist. So they do their anaesthetic handover first, and then the surgical team will do their handover. Usually all the information is transferred at this point in time. Sometimes there's a bedside nursing handover as well. But then the theatre team will leave us to it, and we'll do our assessment and patient plan. One of our issues though with the EPIC and the handover is that there's a lot of fields that need to be completed for our new admissions. So it's very long and can be a bit tedious. And for the person taking the patient, they can just get involved with having to type as quickly as they can, which can, we think, leave room for error sometimes. It's very tricky that the team then focuses on technology sometimes rather than the patient. But we had an advantage of some people take their paper notes and use a little snapshot in time, but EPIC is also quite good. You can kind of pull all the information there. It's just knowing where to find it. So I think then moving forwards, as I said before, education I think is vital to maintain consistency. We've got to be able to adapt with our new technologies and get the team to adapt as well. So we need to identify and simplify the key factors that we want to take forwards with us. We do, I think as Allan has just mentioned, I think adding the readback that Boston do would be really great. It would then summarise everything and bring everyone's focus back in together. We've got to ensure that all our non-verbal communication is not missed, and we maintain things without getting too drawn into the technologies. Ensure our patients are assessed properly and we're not too focused on our phones or the computers, and we notice everything that's happening with the child. Obviously, this is key that we get buy-in from all members of the MDT, because it begins from the pre-op patient planning, runs all the way through theatre, and then the ITU as well. So we have as I said before, the key players in driving everything forwards. So then we have all these aspects of patient planning. It's quite complicated with communication and information sharing. So this is our sort of circle of our little ecosystem of how it works within CICU. So we have the JCC, which is our Joint Cardiac Committee, and that goes on to the pump meeting, and these are all parts of the behind the scenes planning with the multidisciplinary team. The CICU daily briefing, as I mentioned, and then the communications from the theatre team, driving through towards handover, and then doing the post-op plan and the recovery. So there's loads of factors where things can go wrong, and I think the important thing to take home is just everything has to work really well. We have many sort of interdependencies with all these sort of micro systems and processes which determine whether or not the effectiveness of the handover can be improved. And we're always striving to improve things, definitely. As Allan mentioned, there's been some issues recently, or one issue, but we can learn from that and move forwards. So the whole systems approach is really important, and it's essential to resolve all issues within the sort of micro system so that we can improve and move forward and have good patient outcomes.
So thank you very much for the opportunity to share that, our learning with you.
Thank you.
Thanks, Allan, Charlotte. Thanks so much. I have to unshare your screen, please, if you don't mind. I'm going to kick off just a few minutes of questions, if that's okay. There, again, for the audience, it's best if you ask your questions in the Q&A box at the bottom. And there were two questions that you guys, Charlotte, maybe you and Allan could answer as we go into the next talk about specifically how to use Epic and the tags and all that sort of stuff. But one question popped up in the chat box that had me thinking, especially when you did your before and after study, which clearly improved safety. Do you have any information on time spent and sustainability of this process over time? Not only in terms of its efficacy, but also, does it take longer? Does it take shorter? Does it take longer when the new trainees are there in July versus what happens at the end of the year? What kind of information do you have that might be some of the real important characteristics to have this implemented at all the centers that are listening on today?
When we started it, Gil, everybody was worried this would become too complicated and too long-winded and everyone has to get back to theatre and get on with the day. But actually the measures showed it was shorter. That wasn't a goal of the thing to get it shorter, but it was more safety. But we were very pleased that actually it was a much more efficient process, because what was happening before was numerous conversations all over. There'd be conversations down the corridor of theatre, the trainees would be handing over somewhere else, the nursing team, and it was very, very fragmented. So actually by bringing it together, everybody hears the same story and it took much quicker. We haven't audited of how it's transpired or the trainee stuff, as you say. But I'd say one of the hardest things with any QI project is obviously sustainability, and especially over years and new groups coming, new attendings, new trainees. But it has stood the test of time. It's not perfect. It's always evolving. And I value Charlotte's opinion of that. It somehow has stuck and captured people's imagination.
Yes, it has. I think because it works so well, it's been a really good project, and it's still going all these years later. So that kind of speaks.
Is it embraced by the new trainees as they come in? They must think that's the way it's always been, right?
Yeah.
Hopefully, yeah.
Oh, that's good.
Yeah.
Martha, Maiti, and Vicky, you've put some questions in the chat. If I could ask you to put them into the Q&A so they can be answered by the speakers, that would be terrific. And I want to try to keep us to time. So Allan and Charlotte, if it's okay with you, I'm going to move on to our next talk, but they'll be on there in the Q&A box to answer questions. The man you see, thank you for joining us from the UK. That's fantastic.
Thanks for the opportunity.
The man you see with the multiple Pyxis machines behind him in a surgical mask is a good friend, fantastic surgeon, Dr. Jim Tweddel, Chief of Surgery at Cincinnati Children's Hospital Medical Center. To be sure I get all of that right. And Jim is besides being a fantastic surgeon, he's one of the best lecturers I've ever heard. And this is my favorite talk that he gives. And it's not about how to do a Norwood operation, or his excellent experience with a Ross operation, or even other things that he's done in his career that are fantastic. But it's how he's brought his team together to reduce error without any cost at all, which is the theme that Darren and Melissa started. So I'm going to turn this over to Jim, who I think has said he's waiting for the protamine to work. So hopefully you'll have a little bit of time to give us this talk. Thanks, Jim.
Thanks, Gil. I am coming to you from the operating room. That's why I'm wearing a mask. I still haven't quite figured out how exactly what the proper dress code is for these webinars. So I'm trying to figure it out. But anyway, I'm in the operating room. That's why I'm wearing the mask. Although a lot of people say I look better this way. This talk really centers on how we get across important information to the right people at the right time. Communication, which is really a very overused term, and people will frequently point to communication as an issue that resulted in errors that led to injury or morbidity. And I think that's true. The question is, though, is how do we really improve communication? Nothing is so simple that it cannot be misunderstood. And the greatest problem in communication is the illusion that it's been accomplished. And I think that by wiser men than I, those quotes are really accurate. We all know about the pre-procedural timeout. It seems like we have to do this now for anything we do. And this is mandated by a number of organizations as shown here. And this occurs just before the procedure. And certainly this is one way that you can improve communication at no cost. But I wanted to talk about something else. And this is really both to help really clarify the plan of the operation and to communicate that plan with the operating room team. This was not my idea to begin with. This began with Mike Mitchell, my colleague, who is now a real leader in congenital heart surgery. And this began in 2008. We would frequently write down little lists of things to remember during the operation and so on. But Mike had the idea that perhaps it would be best if we sent these plans out via email to the operating room team. There really wasn't an email list at the time or anything like that. All of this stuff evolved as this was ongoing. But the goal of this was to provide the operating room team, the OR team, with a detailed plan of the operation. It included a step-by-step plan. It also included the perfusion strategy. And importantly, any special equipment or instruments, prostheses, et cetera, that might be required. And I thought this was a good idea, and to support this, I also started sending out preoperative plans and made this the rule for everybody. They were relatively simple, still are. They include the patient demographics, the diagnosis, the plan procedure, the list of steps, and the stuff we would need to get the operation done. It might include some summaries of key studies. I find this helpful sometimes. Where was that? What was the aortic valve size in this patient, et cetera? And if I have it there easily accessible, it helps me out as well. And but mostly what it contains is a step-by-step list of the operative steps and the anticipated supplies that we might need. They actually sit down and work on what they call armchair flying. The entire Blue Angels squad sits down in a conference room and pretends they're flying their airplanes through the formations and the maneuvers they'll use during the show. And in this way, they practice what the radio calls will be, and the pilots move imaginary sticks and throttles and aircraft control. And this is actually a video I'm going to show you now of them, between things we will definitely need and things that we might need. What could go wrong? Is this going to be a reduced sternotomy? How will I get access for peripheral access for bypass in the event of resternotomy hemorrhage? Are the vessels in the neck and groins open? And this is something I want to make sure I know about before I get into a problem. What is plan B, and do I need even a plan C potentially? So I try to think of all the steps, how I'm going to do things, and then all of the potential problems and pitfalls. One of my adult heart surgery colleagues in Milwaukee was also a commercial pilot, which was an odd thing. Sometimes a heart surgeon would be flying us to do an organ procurement. But he once told me that he doesn't try to be the best cardiac surgeon, but he does try to be the safest. And I thought, well, you can't be paralyzed by fear, by the potential that something can go wrong. But on the other hand, isn't the best heart surgeon also one of the safest? And I think in the current era, that's absolutely true. When Mike Mitchell began sending out this plan, he started collecting some data on bypass times. And the bypass times are shown in minutes on the vertical column here. And the year is shown here on the horizontal. And the different RACS-1 categories that you're all familiar with are shown in the different colors. And this is when Mike began to send out the preoperative plan. You can see there was a significant drop in his bypass time. Well, he was a young guy at the time, and I was confident he could get better. But when I looked at my own data, I was surprised that my times got shorter also when I started sending out the preoperative plan. So that just taking that extra 15, 20 minutes or so and sort of going over the plan for the next day seems to have a real benefit and a measurable benefit. We sent this plan out to all of the people shown here, and we did a survey to try to get an idea. And it was overwhelmingly, the results were overwhelmingly positive. And I'll just share with you a little bit here. This is one of the questions. Has the standardized operative plan increased the feeling of preparedness for surgery? And overwhelmingly, the respondents agreed with that. And this was one of the comments, that the preoperative plan has revolutionized communication among the complex multidisciplinary teams. Becomes such an important part of the operation that without it, even for simple cases, I do not feel as prepared. In the old days, I was just expected to read the surgeon and anesthesiologist's mind. Now I just read their plans. And by the way, I think these plans also have made the PAs and assistants more adept at dealing with the unexpected. This also shows you the anesthesiologist sent out a plan as well. After we started doing this, they started responding with their anesthetic plan for the patient. This is data from the NPC-QIC. The preoperative communication plan was one of the quality improvement initiatives that we measured. And you can see here that the communication bundle, those programs adhering to this increased over time. And that's certainly very encouraging, but unanticipated reintervention also decreased. I'm not sure that that may be true and unrelated, but I'd like to think there may be a connection there. And also, this is just the 1 year survival in the NPQIC. This is a couple of years old now, but 590 patients, over an 80% 1 year survival, which is really remarkable for all of these centers. And I think some of these efforts to improve communication are helping with that improvement in survival. Again, the challenge of communication, I mean, we all know how to talk and speak to each other and so on, but the real challenge of communication is to figure out the information I need and when I need it. If you're flying in Alaska, you know there may be mountains around, but what you really want to know is the mountain really close to me right now? Not that it's somewhere in the state. So structured and required and timely group communication results in effective communication. I learn what I need to know when I need to know it. It results in the best decision for each patient, prepares the OR team, and achieves the best intraoperative outcomes. I hope that I have convinced you of that. So great teams, whether it's the Green Bay Packers or the Baby Blues Sound Consortium or the Navy Bluegrass Band, need, I think, effective communication really improves their performance. Just one plug here for if the coronavirus vaccine comes out, please get it. You're probably not worth microchipping anyway. I really appreciate the opportunity to speak to everybody today. There's a little picture of the Roebling Bridge in Cincinnati. Construction began before the Civil War. You can still drive on it today. So come to Cincinnati, I'll show you the bridge. Anyway, thanks so much for your attention.
Thanks so much, Jim. You could stop sharing your screen. I'm going to turn this over to Darren and Melissa. And again, remind people to put their questions in the Q&A box.
Thanks, Gil, and thanks, Jim. That was phenomenal. I've heard you give that talk as well, and I would agree with Gil. It's one of my favorites. You know, one of the questions I have is that, as I've heard you talk, and also Allan and Charlotte before you, is that it strikes me that we're having more and more sort of pre-operative planning, right? We have these morning meetings in the ICU. We have surgical conferences. We have now this description of what you all do with your pre-surgical planning. How is there a way to streamline any of this? Is it all necessary? And how do we actually tease out what part of this is most impactful? Because it strikes me that we're talking to each other a lot more, and is that in essence what the benefit is? That we're actually just fostering more inter-team, sort of conversation that didn't used to happen when we thought we could exist in silos?
That's a great question. I mean, I suppose it's the I don't know who said it first, but that we're awash in data but looking for information or something to that effect. But I think that in our case, this particular strategy goes out by an email list, and I think it gets to the people that want to know about it, including the referring cardiologists. They may look at the plan and say, hey, don't forget that kid also has a PFO or something like that might be worthwhile to know. I have to say, I so far, if the communication and the interactions are relatively efficient and the information transferred is important, I don't think we've reached the saturation point where we're just talking too much. I've actually found it to be useful to have the opportunity to think about and re-review some of this data on more than one occasion. It's just sort of sinks in a little bit more. So I think that's my answer. So far, I don't think we've hit the economies of scale have not been met on information transfer, I guess.
And I would agree with you. I think that, I happen to be a big believer in team dynamics and the importance of how well we work together. And that's why Allan, Charlotte's work was so novel when they started it. And you're right. I don't think we have, but it's also not necessarily in our DNA. And, there's so many different folks involved, many of whom bring their own, egos and such to the table, that I think this is a fabulous, all of this stuff is excellent and will pay itself back in spades. Melissa, do you have any other questions? I'm just looking here at the Q&A.
I have one question for Dr. Tweddel. You're clearly a very experienced and accomplished surgeon, and so I'm just curious how you look at these plans with fresh eyes each and every single time. So you've done, I don't know, hundreds of tetralogy repairs. How do you really look at this clearly every single time?
Well, yeah, that's a great question. And if it's a tetralogy repair or a sinus venosus, ASD, or perimembranous VSD, I have to say I don't necessarily go into quite as much active visualization, I guess. But if it's a if it's a complex Fontan where I've got to figure out how I'm going to route something, if it's a complex newborn with a borderline left ventricular outflow tract that I'm contemplating on doing an arch repair on, then I'll spend a little bit more time looking at things. But yeah, I think you're right. There are certainly some cases where I don't spend quite as much time reviewing all the details, but I try to at least give every patient a few minutes of undivided quiet time when putting this together.
That makes sense.
Thanks, Jim. Well, there's going to be some questions that pop up in the Q&A to remind all of the speakers, if you don't mind. We are going to have 2 more talks before the break. Sasha is going to introduce the next one.
Yes, thank you. Now we move from the operating theater of Jim Tweddel and the fantastic tower of Cincinnati we move to Canada, to Hospital for Sick Children in Toronto. And we have a new way to look at surgical performance rounds, thanks to Dr. Honjo, Dr. Allan, and Dr. Moga. Honjo and Allan are cardiovascular surgeon with, of course, interest in surgical innovation and translational research. Moga is a cardiac intensivist with a big interest in the unconventional method to improve healthcare quality. So we are very interested, and thanks to bring us in Toronto.
Thank you very much. Thanks for having us, and greetings from Canada. So we've been already introduced. I'm Dr. Haller. I have to excuse Dr. Honjo, who was hoping to be part of that presentation, but who's currently still in surgery. And Michael Ellis, you can probably speak for yourself.
I'm Michael Ellis. I'll be talking a little bit later in the presentation.
I'm trying to share the screen. Okay, can you see it adequately?
Yep.
Just switching focus here. So what we are introducing or presenting today is a concept that is called surgical performance rounds. It is something that is distinctly different from mortality and morbidity and mortality rounds, and we'll elaborate on that a little bit further. But it's also a concept that probably our hospital has become relatively famous for, because it's a new approach to spark communication, but also closing the loop on patients and their clinical course. So in terms of disclosures, none of us has any to mention, and we're going to outline a little bit of the background and what the concept of these performance rounds really are, as well as the lessons that we've learned and the state that we are in at the moment, but also give an outlook into the future of where we imagine these performance rounds or this concept in general to go. So what are performance rounds? For those that have not heard of this yet, it is generally a multidisciplinary meeting to review each and every surgical patient's course. So that means the complete course, including basically from diagnosis to the patient actually leaving the hospital. The rounds are held usually every Friday. So it's attended by pretty much everyone that is part of the healthcare team. So that includes surgeons and cardiologists, obviously, but also anesthesiologists, perfusionists, nurse practitioners, nurses, admin staff. Pretty much everyone that is part of our heart center is invited to participate and contribute to these rounds. The purpose is to make sure that we review work and that everyone gets a sense of accountability, but also to look at each domain, each specialty involved, each phase of the course, and in part also to have everyone aware of each stage the patient went through on a hospital course, because we all know that we may not be as involved in some parts of a patient's course as we are in others. Compared to morbidity and mortality rounds, we discuss every patient. So irrespective of how good a patient passed through the respective hospital course. Even the smoothest case gets discussed. There is a focus on team performance, not necessarily on patient outcome alone. And we'll look at each phase of the hospitalization as opposed to specific events that are discussed in mortality and morbidity rounds. We've come a long way. So that has been going on for years, and we've obviously gradually improved these performance rounds. As you can see on the bottom left, there is the initial way we presented patients in these rounds, which was a rather crude measure, mainly looking at whether the right decisions at various steps during the hospital course were made and whether the team performance was appropriate. That then transitioned gradually to a much more graphical depiction of the patient's course that helped us to, first of all, summarize adequately important events during a hospital stay, but also to spark the discussion that is held during these rounds. So on the top right corner, you see our current version, and that's a program that we've developed in-house that allows basically us to present relatively many data points on a patient's course. It's a graphical depiction of which state the patient was in throughout a hospital stay. It gives additional information on key diagnostics, so intraoperative echo, discharge echoes, for example, but also length of stays and some metrics that are important. And as you can see here, that is a relatively simple, straightforward case, but it could also be a much more complex procedure where you had, different states where a patient was on ECMO or get a reoperation, etc. You can add specific events, just like the event that you can see as chest tube drainage, that then, when clicked on, shows additional information to that particular event. So you can dive deeper into details of the clinical course if you think that facilitates the discussion. And it's all based on, at the moment, rather crude data entry. It's driven from basically one Excel file per patient that is stored on a central server and that is accessible for everyone in the healthcare team. And so whenever you feel like there is an event that you want to be highlighted in these rounds, then you can search for the file and add comments and add an event or add a metric that you want to be raised and flagged in these rounds. We've developed that, as I said, in-house and programmed that to facilitate and centralize data entry. Also that the slides can be changed while presented. So it's real-time generation of these slides. So if we identified a mistake or so, we would be able to change the curves, the metrics, etc., and add information to that. It's open source, it's multi-platform, so you could theoretically, even though we haven't implemented that yet, watch it on your own tablet when you're attending these rounds. So that's kind of the state we're in at the moment. Michael Ellis, she will then elaborate further on the outlook that we're looking at for these performance rounds.
Thanks, Christoph. So overall, we've been doing performance rounds for just over a decade here at SickKids and have learned some really important things. And I wanted to boil down kind of our major lessons learned to the top 5. First of all, we learned that performance is exceedingly nuanced and is not always tied to outcomes. We kind of started out with a very rudimentary binary performance, good or bad, yes or no. Then moved to, well, maybe it's yes, no, or maybe. But really what we've discovered is that it's a very dynamic process of performance. Kind of looking, this is a great slide that I like to use to depict how we currently think about this, with kind of the performance level being on the y-axis and time on that x-axis. And what we found is that performance, as I said, doesn't always kind of like translate out to outcomes, but that there's this corridor in the middle that's kind of acceptable performance, where it doesn't actually harm the patient, but it might not help the patient either. And so you can envision that the support and the performance that the patient requires evolves over time as the patient's physiology evolves over time as well. Now, certain patients, let's say a kind of standard ASD repair, this corridor of acceptable performance is so broad that it's actually really hard to make that patient course worse or actually significantly better. And so we could actually have poor performance by missing some key things, but it actually doesn't result in a poor patient outcome. Conversely, some very sick and complex patients, this corridor may elevate so much that actually it's not physically, humanly possible to not have a poor patient outcome. And so even though we perform rather well, patient kind of related factors make the outcome not what we wanted it to be. And really unpacking all of that performance then allows us to influence those patients that kind of fall in the middle, where our performance is actually more tightly tied to that patient outcome. Now, we found as well that performance, it's not just one person at one time, that simultaneously we think about individual performance, performance as a team, and performance of our systems. And we divide our discussions in performance runs into these three performance domains. Roughly, we spend about 50% of the time talking about team performance, 30% of the time talking about individual performance, and systems performance comes up about 20% of the time. Kind of our big second lesson learned is that really, instead of just learning from failure, which is that classic M&M framework, where really you're just learning from that left-hand tail of when things go really wrong, you're missing a lot of learning opportunities then. And so what we gear for in performance rounds is to learn about things in that kind of white and then hopefully that green area of how we act as a team. And so can we actually learn from when things go well? So instead of learning from when they go bad to prevent it, can we learn from when things go well and actually make that happen over and over again? This fits very nicely into what's called a safety 2 framework, which is one of the newer things that is happening in the world of patient safety and safety in general to kind of enhance our learning overall. And so when you combine these two thought processes, what you then are able to do is learn from these dramatic performance adjustments. When things went really wrong, how were you able to rescue things? But then get into those early kind of events where, you know what, things actually, performance started dropping off, but we actually rescued it before it reached the patient. And then the ultimate goal would be to, how can we actually push acceptable performance all the way up to exceptional performance that actually creates a better environment for patient care. The next kind of big lesson learned is not to focus so much on technology at the extent that you forget to think about the people. Technology in general, it's a lot easier to focus on this. It's an easier thing to fix usually, and easier solutions to be sought. We've gone through, as you saw in the prior slides, a wide variety of technology to support this process. And what I would encourage people to think about is, this should be a process that's not technology dependent, but technology enabled. And Christoph is very soft-spoken. He kept on saying, we developed this program in-house. The reason why this is a kind of a free process for us right now is he actually coded that program and created that program in-house. And while it certainly has advanced the conversations that we have, we found that regardless of what program we use, whether it's a simple PowerPoint slide, it's about the people in the discussion and not so much the technology itself. And really what it boils down to is, we've talked a lot about communication in all the presentations to date. An oftentimes forgotten part of communication is actually listening to what people are saying to you, and actively listening to what people are saying to you. And so knowing that there is a forum in which patient care can be discussed in a very open way really eliminates these side conversations in the hallway that start happening, the kind of treatment gossip that can start pervading through your organization, that kind of destroy the trust and the feeling of teamwork. When you actually sit and listen to your colleagues, these thought processes of, oh my God, I can't believe they did this, turns into, wow, I actually understand why that happened, and I more and more frequently turns into we and us. It really helps establish the rules of engagement and how we interact with each other in a collegial and a respectful way. So that even outside of performance rounds, if I call up one of my colleagues in the cath lab or one of my surgical colleagues, there's a way that we're expected to interact with each other. The goal isn't always to reach agreement. The goal is to make sure the right thing is being done for the patient. And so disagreement is actually encouraged in some ways, but it's always done in a respectful way that does not become personal and antagonistic. And so really, to be honest, what it boils down to is this somewhat nebulous thing of culture. And so before, if anyone's considering starting this in their own institution, I really encourage you to do a very, very honest assessment of your culture from the beginning. You can see that this can improve a culture, but it's not going to fix a culture that's already broken. If your culture that you live in is one of blame and one of holding other people accountable, all these rounds really do is give a battleground for people to do battle in a much more kind of bloody and meaningful way. This was advocated for and advanced initially strongly by our leadership. And so modeling of the appropriate way to engage in these rounds by leadership is absolutely crucial. And having started off these rounds when I was a fellow, I can't tell you the impact and the power of leadership actually taking personal accountability for their actions and what that had upon everyone else, particularly the trainees. And so when we talk about accountability, it's not holding others accountable. Now, whenever we talk about these personal performance issues, it's invariably people offering up their own, you know what, I would do this differently next time. So it's holding yourself personally accountable for your own behavior. When we ask people, and we have recently, when we ask them, what's the one thing you would want to continue about these rounds, 2/3 of them actually pointed to the culture that it's created. And how that's kind of pervaded how we actually act around each other as a heart center. And so where are we going from here? Performance rounds, actually, we're entering a new phase of what we're looking at. You know, this is now the flagship program of a broader initiative called the Institutional Memory Project within our institution. So what we want to do is combine this understanding that we now have of our organization and our people and our culture with a newly developed data infrastructure so that we can focus on the decisions that we make and how to understand them better and how to improve them. And so really kind of pushing this thought process from using data and translating it from data to information and then eventually into insight and wisdom. And so really driving that then lets us hopefully eventually kind of create what many people aspire to be, which is a learning organization in which we all have a shared vision and take personal accountability for our own kind of personal mastery while engaging in team learning and creating shared mental models and advancing systems thinking as well. And so on behalf of kind of our broader team, thanks for the invitation to talk and present to you all. And I want to acknowledge some of our other team members. Jai Moswe is our technology lead, who's kind of bridging that data infrastructure in with our new institutional memory project. And Michael Mohammed is one of our old cardiology fellows who's spending an extra year with us doing this kind of organizational behavioral research.
Great, Michael, Alice, and all the team at Sick Kids, thank you. Phenomenal work. Time for some questions. We're going to ask one quick question. Just a reminder to Michael, Alice, as we've reminded the other presenters, please take a moment when you're done to just go ahead and hop into the Q&A and give some answers there. Gil, did you have a question you wanted to ask of Michael, Alice, and the team up at Sick Kids?
Unfortunately, us panelists can't put questions in the Q&A box. These talks have just been fantastic. The title of this session was Improving Outcomes at Zero Cost. And I guess the question I have for both the Toronto team and maybe Jim, if he has time, because I know they do a flight plan type analysis that's similar, is there must be some cost, one-time cost in programming, et cetera, but also an ongoing cost of someone to keep track of all this stuff. What is the cost in terms of people?
So that's a great question, Neil. That's actually evolved over the whole kind of spectrum of the rounds that we've done. So we actually used to have a full-time programmer and analyst kind of dedicated to this, who then also went and gathered data on top of it. And we actually lost those resources. And so right now, all of this, and so all of this, as I said, the program was created by someone internally who you could say he cost a lot, but we didn't have to pay him extra, essentially, so that was no additional cost. And then right now, all the data collection is done by fellows and frontline providers. And so we saw that in pushing that data collection to the people that actually know the data the best, gives people that avenue to speak and influence the rounds, and also that's done at no additional cost to us. So right now, it actually is truly no additional cost at all. I would say, again, looking at that technology aspect, the prior versions of performance rounds were simple slides. It was a simple PowerPoint slide, and that was equally, I think, as impactful as these more kind of technology advanced versions that we've had.
I think an important point is certainly that you can't disconnect people too much from the data. You know, when we, at the time where we kind of outsourced it to a non-medical, mainly from an engineering background person to run performance rounds primarily, we certainly lost some information just by the key stakeholder not being of a medical profession. So interpreting a course and what ends up in the end on the slide obviously needs some upfront interpretation, especially if you're not pulling it automatically out of the chart. So keeping that at least to some extent close to the team, and we get lots of our fellows involved there, for example, that definitely helps the communication and the discussion in the end as well.
Thanks, Michelle. Christoph, thank you very much. Jim, real quick, we want to stay at time, but you have a dedicated FTA at Cincinnati Children's to do your flight plans. Is that correct?
Yes, and we are in that PowerPoint presentation phase of it. We borrowed this from the Toronto flight plan rounds, but we are working to develop a computer program that will basically abstract the data and make those slides, and then potentially require minimal additional editing. But it is not at zero cost, that's for sure.
I wanted to thank everybody because, you know, clearly the field haven't been around for a little while. We've gone from competitive programs to sharing best practices. The fact that it's translatable, we've heard 2 talks in a row now where it's translatable from one place to another, modified with something to make it a little bit better, then brought to another program. And many more patients outside of Toronto or Great Ormond Street or Cincinnati are now going to benefit from all of this, which is really terrific. Thank you. Darren and Melissa, you okay if we go forward with the next talk?
Please.
Okay, if you don't mind unsharing your screen. I'm sorry, Melissa, were you going to say something? No? Okay. Thanks. I'm really excited to introduce the next talk for a couple of reasons. It's from my old stomping grounds up at Children's Hospital in Boston. And one of the fantastic surgeons there, Francis Fynn-Thompson, is going to be speaking, but also someone I've known for probably about 3 decades, if I remember correctly, Jason. We go way back when we were both young. We played Ultimate together, we're colleagues. Has done some great work at Children's Hospital in Boston, and I'm really, really looking forward to your talk on healthy work environment and authentic leadership. Thank you.
All right, well, thank you. Thank you for that. Hopefully you can hear us through these masks. We'll get started here. So hopefully that's coming through okay. So
I look great, Jason. Thanks.
Perfect. Thank you. So we're going to talk a bit about building and sustaining a healthy work environment in the cardiovascular operating room. So neither of us have any conflicts to disclose. I won't mention the Green Bay Packers slide that did definitely make me feel a little conflicted inside, but we'll go on. So this afternoon, we're just going to talk, a bit about the American Association of Critical Care Nurses Healthy Work Environment Framework and the assessment tool, and how we use that on our ongoing journey to excellence. Also, we're going to talk about the utilization of an improvement science strategy to target the healthy work environment in the cardiovascular operating room. So back in 2005, AACN published their first paper talking about establishing and sustaining healthy work environments in a journey to excellence. And in this, they outlined several cases regarding healthy work environment and unhealthy behaviors and things along those lines, and really started to lay the groundwork for the healthy work environment and for the work that was to come. And they updated this work in their second edition just a few years ago in 2016. So the evidence-based model that they created really came out of some work, some really collaborative work that was spearheaded by AACN. They partnered with the American College of Chest Physicians and identified essential standards for establishing and sustaining a healthy work environment. So we're going to talk a bit about each of those standards, but it's important to understand that these standards all really align directly with the core competencies for health professionals that are recommended by the Institute of Medicine. So they represent an evidence-based and relationship-centered principle of professional performance. And there are other professional organizations that have gotten on board either from the beginning or since then, and include some pretty well-known and very well-represented professional societies. So the healthy work environment model, as you see here, really talks about the 6 standards of the healthy work environment and how they all work together to enhance optimal patient outcomes and clinical excellence. And so right in the middle here is where we always try to be. That's what's best for our teams and our patients. So each of these evidence-based standards interact in a pretty dynamic way to promote clinical and operational excellence for optimal patient outcomes. So you can see each of the 6 standards listed here and a little bit of information sort of defining them and outlining important components of them. So a few years after their first paper came out in November of 2009, AACN launched a healthy work environment assessment tool, and they made this available to everybody for free. It's an 18-question web-based survey that is available through their website. And it's really a generalizable survey, and you can use it in any organization, in any department, any clinical area. And what it does is it provides a quantitative assessment that are based on those 6 standards of the healthy work environment framework. And it's really intended, its main intent is to identify areas for improvement so that each of those areas can identify targeted initiatives to improve their scores. So just a little bit of history from our work here at Boston Children's with the Healthy Work Environment Assessment Tool. For just about the past decade, we have been working with it. So we were early adopters and began surveying our areas across the heart center and across critical care. And in 2014, so we were 4 or 5 years into using the survey tool, we led a hospital-wide validation. And the intent of that and the findings from that really validated the survey across disciplines, which is something that we had done from the beginning. We always included all of the nursing staff, the physician teams, the administrative staff, anybody and everybody who in those clinical environments interacted as part of the team or interacted with the patients were always invited to participate in the survey. So in 2014, we did this hospital-wide and validated it for use on interdisciplinary teams, as well as for use in non-critical care environments. So again, initially AACN validated this tool for nurses in critical care environments. And then in 2019, we continued with a hospital-wide and what will now be an annual measurement. So typically when we do this survey in our areas, we leave it open for about a month, 3 to 4 weeks, and it's performed the same way every time. All the surveys are open for a month, and the responses go directly to AACN. They go directly through their website, they're anonymous, and once the survey closes out, AACN creates a report and sends it back to the survey leader. And as I said before, all of the interdisciplinary staff are invited to complete the survey. So just a brief overview of the cardiovascular operating room here at Boston Children's. We do about 1,400 cases annually on average. It's about 300 or so of those are done directly in the ICU. There are about roughly 70 interdisciplinary team members, and they include members from all across every discipline, from attending surgeons, clinical assistants, surgical residents, surgical scrub techs, the entire team. And so here you can see the healthy work environment scores by each standard in each of the areas of the heart center for the last decade. And you can see the cardiac OR on the right here and all of the scores from the beginning. So I'll highlight the areas leading up to 2015, which is some of the time we're going to focus on now and what we're going to talk a bit about. So you can see, as was our experience in most areas, usually the first time you take the survey, the scores are often pretty good. And you can see here that was the best year that we had. And then for the following 3 surveys, the scores kind of trended downward. And by 2015, they were solidly not good. They were solidly in the needs improvement category with the exception of one of them. So upon looking at these scores and reviewing them and seeing the trends, it really was a call to action for us, for our team, and for all of the leaders in the Heart Center. So these results really pointed to a significant opportunity for improvement. As you just saw on the last slide, scores for 5 of the 6 evidence-based standards were in the needs improvement range. So individuals and organizations learn and evolve through conscious, deliberate action. Deliberate action is ethical. And when the time to act has come, it is unethical not to do something. And so when you think about the data that was in front of us and you think about the trend of those scores, it became clear to the entire team that we all had to own this and work on improving it. And so immediately we came up with an improvement strategy. We developed a pretty comprehensive action plan and implemented it over the course of 12 months. There was an authentic commitment from the entire team that was reinforced by cardiovascular nursing and surgical leadership. At the beginning of this process, we established a healthy work environment ambassador team. And every member of the cardiac OR team had a representative, at least one representative on the team, often 2 or 3. And this team really spearheaded and drove forward much of the work that was accomplished. And the team was supported by a nurse scientist and a quality improvement consultant. So initially, and then several times since, we start with a review of the 6 evidence-based standards. And then what you see pictured here are what we call brainstorming sessions. And so what we would do is invite the entire cardiac OR team to come to this brainstorming session. And what we do is in a pretty large conference room, hang up large posters, one for each of the 6 standards. And we would break everybody up into 6 groups. assign one to each of the standards, and they'd rotate through. And their job at each of those stations was to brainstorm together in their groups things that we do well in that particular standard. So if we're talking about skilled communication, how do we communicate well with each other? And then things that we need to spend some time and energy on improving. So the caveat to that was if we were going to identify issues that we needed to focus on, they also needed to suggest ways that we could do that. So they could identify a problem, but they had to try to identify a solution as well. And so from that work, we were able to develop an action plan and key driver diagram here. And so these change strategies really came out of some of that initial staff brainstorming session. The Healthy Work Environment Ambassador Group got together. We went through all of the sticky notes. We identified the themes and really looked for concrete ways to move these forward. We identified the outcomes really in each of the 6 standards. And by working this way, it got us to our key driver, which was over the course of 12 months to create an environment of excellence in the Boston Children's Hospital Cardiac OR. And so through that work, the Healthy Work Environment Ambassador Group was able to come up with many targeted initiatives to address some of the concerns of the team and things that were identified in those brainstorming sessions and the subsequent ones. And this is really just a small snapshot of some of the targeted initiatives that were in place. Many were done very quickly, and some were done over the course of months and a couple of years. So here's a summary of the last decade of the overall healthy work environment scores for the cardiac OR. And so you can see the first few years started off pretty well and then kind of trended downwards, bounced back up. And I wanted to highlight this because it is an ongoing process. It is not something that you could spend a little bit of time on and then walk away from. It's something that really has to continue throughout. We were able to, in 2016, have a pretty significant increase from 2.7 up to 3.3 as an overall score, and then sustain that for the following couple of years, and then have another significant increase for 2019 and 2020. And I will note that this most recent score was done right as the COVID pandemic was starting and things were shutting down, and still had a pretty good participation rate, normal for this particular survey for us. And so here's just another a view of the scores with a little more detail. So you can see the participation rates typically above 50% for the last several years. And then in 2010, so just about a decade ago, the real indicator was developed here at Boston Children's in the Heart Center. And it really was developed so that in between these annual surveys that we were doing to assess the health of the work environment, this would give us a better way to get a snapshot of what's happening in the work environment from day to day. So what were the sort of things that were the most influential factors, both positive and negative? It is and still to this day widely available for all the interdisciplinary team members in areas throughout the cardiac OR and throughout the Heart Center. It's available on paper and also available through an internet link that's on many of the desktops. And it, like I said, it allows us really to identify opportunities for improvement in the moment. And probably just as importantly, it allows us to recognize the importance of teamwork and interdisciplinary collaboration to support the excellence in clinical delivery of care. So people don't only fill it out just to, note that they had a bad day or that something went wrong. They'll fill it out to show some gratitude and appreciation when things go really well.
Okay. Just to echo what Jason said specifically about the daily assessment tool, this real-time indicator, I think it's particularly important to reinforce the fact that this also includes the surgeons, the surgical team, the surgical fellows, the entire cardiac operating room staff. And the information that's gleaned from this is actually shared in real time with both nursing and physician leadership. And so what it allows us to do is to address issues that come up in real time rather than allow them to fester and over time bring down the entire culture of the operating room. And we've found that we've been able to get ahead of a lot of issues as they develop in the operating room by addressing these issues.
And here you can see the last couple of years, we share the results quarterly, though as Francis said, we really see them in real time as they come in. And our benchmark for this is really to have 90% of the scores be at least in the satisfactory, good, or great range. We really want to see them all at this 90% line or better, and really try to minimize the harder scores, the I need a new job, or I'm frustrated, or my day was barely tolerable. So as we conclude, the healthy work environment framework really is a roadmap that we have used and we believe is certainly achievable and sustainable across all different environments and all different institutions, really to sustain a culture of excellence. And it's helped us maintain a culture of health in the work environment. It's really allowed us to put the focus on staff well-being and optimal patient outcomes and how those things are so connected. And I think we've seen, the impact of communication in some of the other talks and how important that is to patient outcomes. And it's a critical part of the healthy work environment as well. And so this is a continuous process, though, and it's one that, from our healthy work environment ambassador team and from the leadership, top to bottom in the Heart Center, it's part of what happens every day, and all clinicians and staff are accountable to it. So thank you.
Thanks, Jason. And Francis, Darren, the last time Darren and Francis and I were together was in the beautiful town of Ortigia in Sicily. And boy, I sure miss that. Darren, do you have any, Melissa was there as well. Do you have any questions for the great team from Boston? And thank you for that great presentation and the transparency. It's fantastic.
Yeah, I think it's really outstanding work. Thanks, Jason and Francis. One question I have is, when I give some of these talks, there's a great study that I like to show that shows the discrepant opinions of teamwork between team members of different disciplines. They surveyed ICU nurses, surgeons, and anesthesiologists, and their perceptions of teamwork and culture were quite different. You spent a lot of time talking about the OR. Have you noticed this changing the perception of different disciplines that are that don't necessarily live in the operative environment but work with you all the time?
I think one of the things, a couple of the times, so that survey is only a couple times we've been able to host it on our own and really break it down into different demographics and see how surgeons viewed the health of the OR and how anesthesiologists did, and really break it down by discipline. And that definitely reinforced very different perspectives on the health of the work environment, for sure. And every time we've done that in different areas, it's been similar themes where physicians tended to rate the health of the work environment a bit higher than nurses and some of the other staff. And so I think that's probably continues to be true today, though I think it's engaged the surgeons and anesthesiologists in a really different way than in years past.
It probably won't come as a surprise to anyone that there was a lot of skepticism among the surgical group about the value of work like this. That being said, I think over the last 5 years that we've been engaged in this process, everyone has come to understand the value of this. And there's some real world impacts. The improvement in the culture in the operating room and being accountable for behavior and the interactions and good communication has resulted in our ability over the last 5 years to recruit new staff members. We had a problem retention of experienced OR nurses, perfusionists, and that has changed dramatically. We've been able to recruit new staff members. We've been able to recruit new perfusionists, and all of the surgeons can now see the tangible benefits of this improved culture within the operating room. I mean, it's something we talk openly about. It's how different things are now versus the way they were 5 years ago. And so, you know, I think that once you lean into this type of work and you stay committed to it and you stay open to it, I mean, I think that the clear benefits that everyone has experienced.
Francis, do you think that the insight you've gleaned from this work in the OR has changed any of the dynamics that you, or the way you approach you and the surgical team approach the ICU team?
Absolutely. In fact, given the success we've had in the operating room using this sort of very specific methodology, using the 6 domains of authentic leadership and skilled communication and all of that, we've applied that now to the ICU and our interaction with the ICU. And so that's actually an ongoing process right now, where we have an ambassador group, we meet, there's real buy-in from our surgical leadership, our ICU leadership, and we're utilizing the same methodology. We're doing something similar, specifically the perfusion group. So I think this is methodology that could be applied to any group of skilled clinicians that work together.
Mm-hmm. That's great.
No, that's really fantastic. And there was a question in the box, the chat box, that hopefully one of you will answer, that I found interesting, because we always look at things through our own lens. It said, you know, traditionally surgeons are thought to be difficult to work with, et cetera, et cetera. And I'm glad you're on there, Francis and Sasha and others. And I would bet if you ask surgeons, they would probably say intensivists are difficult to work with, and vice versa. And I think once you do the kind of work your team is doing and everybody's on the same team and you get rid of the us and the them, you get a real collaborative practice. So really congratulations on that work. I think it's terrific. This is, there's Q&As in the box for your team, Jason and Francis. We're running a little over. So what I want to do is just move right on to our audience poll. Do you see these slides now?
Yes.
Bueller? Okay, great. This is just very quick. As a member of the organizing team of the World Congress of Congenital Cardiac Surgery, I want to go through this very quickly. I just wanted people to know that this, of course, has caused the problem, COVID here. So we have made the difficult but correct decision to move the dates of the World Congress of Pediatric Cardiology and Cardiac Surgery to 2023. If you'd like to mark those dates down. And again, just like the webinar here has been a bright spot from the COVID pandemic, I do also want to point out that throughout the next 2 years, the World Congress Scientific Committee and all the content that we received are going to be presented over the next couple of years by the Congenital Heart Academy and some of our other educational partners for free, as we've been doing it for now. Listen more for that. Our web address will be changing. We're taking a short hiatus after we made this decision and went through the Kubler-Ross stages of grief and now acceptance. And I will get you more information on that. Now sorry, I missed that. The most important thing I'd like you to do now, we're gonna take just a short little 5-minute respite from slides and didactics to get into some audience participation. So if you have the opportunity, either another browser window on your desktop or your laptop, or use an alternative device, such as your mobile phone or an iPad or something like that. And please go to this web link, which is ahaslides.com/CICU. And I'm going to move over to that presentation right now, and I will give you that link in just a second. Let me go here. Okay. So we should have an opportunity now. You should see my screen. And I have to move a few things around here, sorry. But I'm hoping that you can open this up on your alternative browser. Oh, something went wrong, reload. I love when it does this. Please hold. Okay, so we have a few people logged on already. This is going to be a practice session. So again, this is ahaslides.com/CICU. And this is a practice, so you get to use it. You should be able to see this either on your laptop or on your phone. People are logging on right now. And we're going to see which of the images that you can see here are birds. And we could see we have about 60 of us logged in. So that's about a fifth of the audience. I hope more of you can participate because we have some interesting questions coming up. And of course, on the left is an American Eagle. The third one up there is Larry Bird, NBA player. The real bird is the fifth one there. Charlie Parker is the father of bebop jazz. And for those of you in cardiac intensive care, senior cardiac intensivist, Dr. Jeff Bird on the right. See, a few more people are logging on. We'll give you, we're going to go to the next slide. At the top, it should say, move to the next slide. We're up to 80, 81 people now. It's another practice question. Okay, the best, so you can advance your slide on your phone, or you should see this on your computer screen. What's the best type of pizza? Why anybody would put pineapple on pizza, I don't know, but a couple of you do. Got some vegetarians, a couple of meat eaters here. And these are the kind of interactive slides that we're trying out now with the Congenital Heart Academy. We'd love some feedback on whether you think these work, what kind of things we could ask the audience. Is it difficult to log on from where you are? Things along those lines. We're up to about 100 of you now, so I'm going to go into the audience poll questions based on our topics from today. Some of these are questions that we're just curious about, and others have to do with the talks you've heard and will be hearing. Tell us a little bit about yourself. Let's start with gender. This also helps the presenters. One of the challenges, I learned this from Erica Sood last week. She said one of the challenges when we do these webinars is you just don't know your audience. But when you do this sort of thing, you can almost imagine what the audience looks like. This question and the next demographic one that I'll show you. So we're roughly even, well, maybe 60%, 57% female. And as more people answer, it doesn't really change very much. The next question then is trying to get an idea of the experience of the group here. What age bracket are you in? It always takes us older people longer to figure out how to use these mobile devices. So wow, 12% in my age category. That's pretty good. All right, we're getting a few more people. Again, just to remind you, if you open up another web browser or your phone, it's ahaslides.com/CICU. Okay, now we're going to move on into just a couple more questions about you. Where do you live? Some people have already answered a few. They've moved forward to the next slide. Let me try this. Let's try again here. Oh, I forgot to, this was my bad. I forgot to delete the answers from our last webinar. So the information that we're getting right now is probably not accurate. And I apologize. I'm learning too, guys. Okay, so this is, write down 2 words that describe why you take care of critically ill children with heart disease. 2 words that you can think of as to why you take care of critically ill kids with heart disease. Love these word clouds. There's really a combination of science and humanism here, which I find really, really fascinating and very interesting. But most of it is the humanistic stuff of what we do. I don't see interpreting blood gases on there at all. Fantastic. Move to the next one. How'd you learn about this webinar? Oh, I have to open it, I'm sorry. At our last webinar, interestingly, even in this day and age of social media, the majority was email, which still looks to be about the same as what we're seeing here. The director of social media for the World Congress, Grace Van Leeuwen's on this, as well as Jill Zender, who's the director of social media for the Pediatric Cardiac Intensive Care Society. Thank you both for your work. We'll need to look into this and find out ways that we can spread the word a little bit wider this way. And I'd ask the panelists to have their mics open if you have questions or comments as this stuff goes forward. What's your daily practice? What type of caregiver are you? I would imagine that that pink bar in this webinar sponsored by the Cardiac Intensive Care Society would be the one that would be the largest, but you see 15 cardiac surgeons are on the webinar. That's fantastic. Very good. And I suspect that this is representative of the larger 400 people who logged in earlier. All right, so here's interesting. I'm gonna move back up to Dr. Goldman's talk earlier along. What are a couple words that you could use right now to describe the current situation of handoffs in your unit? Organized and disorganized, or bouncing back and forth. It is interesting to see some of these words that are there. Decent, that's a good one. Noisy. And we're going to be, all this stuff will be on our YouTube channel and eventually on our webinar for people to, on our webpage for people to take a look at. Now, Allan, it's looking like disorganized. Charlotte, this stuff, I'm hoping that people are going to have learned a lot from your talk, which I think was really excellent. Always improving and need to do better right next to that over there. That's what I like to see. Okay, so this is a yes, no. We have a structured handoff. Yes, sort of, or no, it's more like a circus. All right, so it's looking like half of the audience has some opportunity to bring some of these skills that we heard about earlier. Good. Please don't answer if you currently have a structured handoff. What's the biggest barrier to a structured handoff in your institution, do you think? One of the nice parts about this is that it's anonymous. I think I'd love to hear Jason and Francis's take on this. And maybe this would be an interesting way. Obviously, it's not scientific. It's just sort of looking at ideas that come out. But the prominent words that I see there are egoism, engagement, surgeon, culture. And that's been brought up multiple times in these early talks, is, you know, none of these tools make a bad culture good, but they are certainly good ways of getting people involved in culture improvement. And then the rest just follows. Thanks everybody for your honesty there. I'm going to move to the next question in the interest of time. Again, I would like to adopt the handoff system described, and we already use a handoff system. Very quickly on this one, if you could answer just yes or no. So Allan and Charlotte, it looks like you've done your job. You might be getting a lot of emails. And that's really nice to see all the people that have benefited from your talk today. Okay, what are the major barriers to performance rounds in your institution. Move to the next slide and see this one. So again, culture comes down to culture. About 15 people are already doing performance rounds. And we're getting close to the end of our, I thought this would be an interesting word cloud. Use 3 words to describe the morale in your, it can be your general ICU or your cardiac ICU. Now, I don't know if this is selection bias of the people that have decided to get on a Congenital Heart Academy ICU webinar, or this is the state of play.
I think, Gil, you know, as I look at this, I got to tell you, I think this is exactly why this first session is so important, is that there is a growing recognition about the value of this in our field. You know, we're a young field compared to most of medicine. And there's been such an intense focus on refining our clinical practice that I think the human element has fallen by the wayside, unintentionally so. But those of us who value that sort of thing and study it and put forth effort to improve it, I think Jason, I saw nodding his head a bit, but I think this is the next frontier in cardiac critical care and congenital heart care, to be completely honest. You can have the best surgeon, the best ICU, all of that. If your culture stinks, your results are going to suffer.
Yeah, I think you know, the more we learn about this, the more we learn about how important, you know, culture is and the environment is, and how, you know, we want to focus on safety, but you have, you know, a team of nurses or a team of residents or other staff who can't raise concerns because they don't feel comfortable, you know, maybe, or they're worried about being wrong. You know, what are we doing? That is the opposite of, you know, focusing on safety. You know, it all starts here. This is not, it's hard work, but it's not hard. It's not hard to do. You know, it requires leadership, and you've got to have ownership of it.
Can I push that a little farther, Jason?
Yeah.
I specifically think it requires leadership from the chief.
It would be exceedingly challenging to do it without that, for sure.
You can have all the champions in the world, but if it's not poo-pooed by the chief, or if it is poo-pooed by the chief of surgery, or the chief of the ICU, or the chief of cardiology, or the director of nursing, it's unlikely to succeed.
And you're absolutely right. And as we all know, you know, many of us are swayed by data. And you know, when you have data, and you can link it to your outcomes, and you can link it to whatever those outcomes are, whether it's staff turnover and how much that costs, the financial cost, and the cost of training new staff continuously. Maybe you're having a hard time retaining or recruiting ICU faculty. All of those things play into it. And so you make the case from even just that perspective. It requires top to bottom buy-in and leadership. It doesn't happen without it, for sure.
Well, I don't have data, but I have a word cloud. And I'm happy to share it with anybody who needs it.
I think the other challenge, Jason, is that you can't, you're right, this is probably the fundamental talk in this session about what really costs nothing. I mean, this doesn't cost a penny to do it. The problem is for those people who like data, it's very hard to measure. It's very hard to measure. And that's the challenge.
It is, and that's where that healthy work environment assessment tool comes in. You know, it's free. You don't even have to be a member of AACN to get it and to use it. And you know, I'm happy if anyone on the webinar wants to reach out. I'm sure I'm happy to have a chat with anyone that wants some guidance, or you know, doesn't even know where to start, whatever it is. But you know, even just starting with the survey to get a pulse of you know, what the team is seeing and experiencing, you have to start somewhere.
And again, I'm going to share all this with everybody. I didn't make this after you said it, Darren, but there has been some interesting studies that show the difference between team members in the various units. So these are physicians who've answered that look like half say the collaborative work environment, roughly half, absolutely or most of the time, and half some of the time, and maybe on a good day. So those are for the, any other physicians that want to answer, please answer that now. Okay, and let's do this one. Nurses and advanced practitioners. Let's see what the similarities or differences are. It's funny how it changes over time. You know, I wasn't sure which direction that was going to go. It started to go up and up. So this is actually, on this webinar, it's actually pretty close between the nurses and the APPs. And that's really reassuring. Again, it's hard to know the selection bias of the people that log on to a webinar, and individual units may be very, your individual results may vary. Okay, now we're getting into some of these great science talks that we're going to hear, which will be like 10-minute talks at various international meetings. How many, we're going to hear a talk on Levosimendan. How many people have Levosimendan in your unit? For us at Children's National, we probably could get it, but we'd have to drive to Canada, I suspect. So half of, so Roberta, half of the audience don't have this opportunity. I'm hoping when we get to your talk, you're going to be able to convince them that we need to. This first talk, we're going to hear about transthoracic intracardiac lines. I made these before I got your questions, Amy Jo, and I will put yours up shortly. Boy, I wonder if we had asked this question 10 years ago, what this answer might have been. Melissa, this is very interesting, don't you think? That half of the people here, roughly, or maybe 40%, do have patients held in their ICU. I didn't think it was going to be that high, but that's really great to see.
Yeah.
All right, what are some of the essential components needed to successfully mobilize patients? You can check on more than one answer. I have to tell you, Amy Jo, when I first answered this question, when you sent it, I got it wrong. So it's really going to be interesting for you to talk about this in the second talk we have in the next session, in the next part of the session. Okay. Having new intracardiac catheter standards and procedures are all that are required so that patients receive optimal early mobilization during the ICU stay. All we need is standards and procedures. I don't know what Amy Jo is going to talk about in her talk, but I am glad to see that the majority of the people here are saying no at this point. Just a couple more. We have a routine process in my unit to screen for catheter-associated thrombus. It's one of those things that makes you go, All right, I'm curious to see if that's going to be a recommendation from the Pediatric Cardiac Critical Care Colloquium Consortium, one of those. You'll hear that paper shortly. Please list 3 ICU topics you'd like to see in our next webinar. This is for the leadership at PCICS. Nothing. We've covered them all. Are they not coming on? There's a few coming up now. Okay. This is particularly helpful, everybody, and take your time and put these in because this will be very nice for us to to help plan. I do want to mention that there's going to be a first ever collaboration between the Cardiac Neurodevelopmental Outcome Collaborative and the Pediatric Cardiac Intensive Care Society, along with the Congenital Heart Academy, for exactly what we can do for neurodevelopment in the cardiac intensive care unit. That will be in early December. Sasha, Grace, we've got our work cut out for us here.
That's great. I have to analyze all of that, but still there's a lot to be done. This is nice.
Well, I guess we're going to be going into 2021. I mean, look at this. You know, it's interesting. There's pretty much single entries on a lot of things, and ECMO just stands out. Grace ran 2 really successful ECMO webinars, including one with a keynote lecture by Robert Bartlett that are available on the Congenital Heart Academy YouTube channel. And for those of you interested in ECMO and cardiac patients, please feel free to log on to our YouTube channel. All right, so those will come back. What improvements can we make on this webinar? I have a feeling I know what's coming up, but. Any suggestions? All right, I like that one. That's good. I think I'm supposed to do this. Keep it going. Oh, these are for these just provide food and drink. Excellent. These are great. I'm really surprised I have not seen continuing education credits pop up here. And that's been a discussion that we've had. It's a fair amount of cost and time. That clearly came from a surgeon. But we are at least looking for this as we move forward into the World Congress talks. Well, this is great. Thank you. Okay, last 2 slides. I'm a member of the Pediatric Cardiac Intensive Care Society. We'd love to know who is and who would like to be. If you'd like to join and would you like to know a little bit more about this, you can swipe on that address right up there. Melissa and Darren, Melissa's the incoming president. Do you want to say a little bit more about what the strategy is going to be and what we plan to do?
Sure. So PCICS is, do you just mean about the meeting, Gil? I'll just talk about
not only the meeting, but what what you get as a member, how we're trying to be international.
Okay, sure.
Much better.
Yes. So first about the meeting, since that's coming up in early December 9th to the 11th, we have, like many societies, moved to a full virtual meeting. It will be 3 days with some really interesting topics and very sort of time-sensitive, relevant topics. Some of the ones I'm most looking forward to are ones related to COVID and how that's impacted our world, and ones that are related to racial equity in our field and within our patient population. And then we have another really exciting one about neurodevelopment. So there's a whole variety of topics. So I encourage you to join PCICS and also, register for the meeting. The other things that are available through PCICS, we have nursing special interest groups. So for nurses who are interested in networking with people who do the exact same work that they do every day, this is a really amazing opportunity. There are meetings with these groups routinely. They're working on specific projects. They're helping to define best practice. So the nursing special interest groups are really a good way to get involved. We're also hoping in the next year or so to expand the special interest groups to other disciplines. So keep an eye out for that. There are curriculum available on the website. There's the handbook available on our website. Just a word to the wise, we're revising the handbook now, so that a new edition will be out in early 2021. And then my colleague and one of my favorite people to work with, Dot Becca, is leading the nurse curriculum, which will also be out in 2021. So lots going on through PCICS, and please don't hesitate to reach out with any questions, and be sure to visit the website.
Thanks, Melissa. And Jill, who's on here, we're going to save all of these for you. This is so helpful to all of us. Thank you for taking a short little break in all of the scientific content. We heard some of this here, so in the essence of time, I'm going to move forward. I'm going to stop sharing the screen, and Sasha is going to introduce our next speaker.
Yes, thank you again for the big, fantastic poll. We now knows more from the people, and we are very happy to collaborate with Melissa and Darren. It's a really amazing opportunity. Now we come back to the fantastic Italy, and it's my pleasure to present my colleague Roberta Iacobelli, who is a pediatric cardiologist in Bambino Gesù in Rome. She coordinates the echocardiographic imaging both in pediatric cardiac intensive care and in operating room. And she has a lot of publication, and today she will talk about effect of Levosimendan on ventriculo-arterial coupling and cardiac efficiency in pediatric patients with single ventricle physiology after surgical palliation. It's a retrospective study. Welcome, Roberta.
Okay. So hello to everybody. Thank you again, Sasha, for this very nice presentation. And also to all my colleagues in Rome who helped me in the preparation of this very nice paper. Sorry. I have no disclosures. Okay. Pharmacological manipulation of contractility and afterload is often used in a management of pediatric patients with single ventricle physiology, mainly in the post-op setting after the post-op stage 1 palliation and also chronically. Early post-surgical low cardiac output syndrome is typically managed with incremental dose of catecholamines and when needed vasoconstrictors. However, palliated univentricular hearts may show signs of heart failure even after several days following surgery. In this setting, heart failure can be managed with inodilator drugs, and recently Levosimendan has been proposed as an alternative inodilator both in the adult and in pediatric cardiac surgery. The important role of VA coupling in the physiology and also in the pathophysiology of cardiac and aortic mechanics has long been recognized. VA coupling, which is the ratio of arterial elastance to end-systolic elastance, was proposed in fact by Suga and Sagawa as a consistent method for quantifying the performance of the entire cardiovascular system. So particularly the effects of inotropic drugs, vasodilators and vasoconstrictors are well known in terms of VA coupling and cardiac mechanical efficiency. As an example, as you can see in the left side of this cartoon, inotropes administration increase contractility or result in rise in systolic elastance and increased stroke work for any value of VA coupling, but linear relationship between the total myocardial work and oxygen consumption is upward shifted because of the increased oxygen basal consumption. So the effects of all this pharmacological approach may need to be evaluated by VA coupling to be fully appreciated. The coupling between the intrinsic contractile state of the myocardium and the post-op vascular impedance has recently been described in children with congenital heart disease by our group and by others, and also in adults with left ventricular dysfunction. But nowadays, we have no information available about VA coupling in neonates with single ventricle physiology. VA coupling is the ratio of the arterial elastance to end-systolic elastance. But while arterial elastance can be computed as the end-systolic pressure stroke volume ratio, Emax is ideally assessed invasively using data from a family of PV loops. So nowadays we have single beat methods allowing for non-invasive estimation of Emax using simple echo measurements. In our study, 9 HLHS-like patients with signs of low cardiac output syndrome several days after first stage Norwood procedure or hybrid procedure respectively were retrospectively enrolled. Mitral and aortic atresia, as you can see from this table, was present in 5 patients. Double outlet right ventricle with mitral atresia and hypoplastic left ventricle in 2, critical aortic stenosis with hypoplastic left ventricle in 1, and multiple VSD and hypoplastic left ventricle in 1. So levosimendan infusion at the dosage of 0.1 micrograms kilograms per minute without a loading dose was administered for 72 hours added to ongoing therapy in patients with signs of subacute heart failure, so more than 24 hours after surgery. Inclusion criteria were levosimendan infusion with at least 2 of the following: requirement of high diuretic dose, tachycardia, polypnea, need of mechanical ventilation, and the availability of echo not more than 6 hours before and after drug stop, while the exclusion criteria were the presence of open sternum during levo administration, epinephrine dosage more than 0.1 microgram kilograms per minute, or vasopressin at any dose, and finally the presence or any residual lesions such as TR, severe TR, reverse coarctation in hybrid, etc. Pre-operative and post-operative infusion 2-dimensional echo examinations recorded end systolic volume and then diastolic volume from the 4-chamber apical views using the modified Simpson method, as you can see here, used as a surrogate of ventricular right dimension. And this is the echo of one patient we enrolled before levosimendan infusion and after levosimendan infusion. You just see on eyeballing just a slight improvement of ventricular contractility. Okay, according to the following formulas, we calculated systolic elastance as the ratio of mean arterial pressure and systolic volume, diastolic elastance, arterial elastance as the ratio of mean arterial pressure to stroke volume, and finally VA coupling and cardiac mechanical efficiency. Median weight was 2.8 kilograms with a median age of 16.5 days, respectively. 4 patients were readmitted to pediatric cardiac intensive care from the cardiology ward to manage heart failure, whereas the others were managed in a late postoperative course. After 72 hours of levo infusion, metabolic parameters were not changed, as well as oxygenation, and all intubated patients were extubated after a median time of 48 hours. As you can see on the right side of this cartoon, heart rate significantly decreased and systolic volume also significantly decreased, with consequent stroke volume increase. Arterial elastance, Emax, and VA coupling and cardiac mechanical efficiency also showed significant modifications, while diastolic elastance didn't modify. When predictors of VA coupling difference pre and post infusion were analyzed, only lower age showed significant association. Also, from this table, you can see all the summary of all significant modifications in all dimension parameters, and at the end of the slide, also a significant improvement in indexed oxygen delivery. There are a number of limitations in this study that need to be highlighted. First of all, the small sample size of patients who received Levo without a specifically designed protocol, and therefore the risk of selection bias. Moreover, no conclusion can be drawn about the definitive effects of this strategy on clinical outcomes and mortality in this high-risk population. Moreover, we did not monitor the duration of these described effects. And finally, echo assessment of stroke volume in single and right ventricles anatomy may be challenging due to the anatomy of the examined single ventricle. But energetic calculation applied in this study represents a simplification of the actual invasive elastance measurements, in particular the assumption that V0 is equal to 0 may lead to an underestimation of Emax and diastolic elastance. However, recent literature has confirmed their reliability. In conclusion, in a small series of patients with HS-like anatomy, Levosimendan increased stroke volume and stroke work with lower arterial elastance and higher contractility expressed by Emax, leading to decreased VAC value and increased cardiomechanical efficiency. Reduction of heart rate contributed to hemodynamic improvement. In the future, monitoring of VA coupling values may provide further information on cardiovascular components of palliated univentricular circulation showing signs of heart failure, but more mechanistic and VAC guided therapy clinical trial are needed in this field. Thank you for your attention.
Thank you so much, Dr. Iacobelli. Just for the sake of time, we're going to move forward with the next presentation. I encourage all of the attendees to please put any Q&A, any questions in the Q&A box, and we'll answer them that way. Our next speaker is Dr. Jo Lisanti. She has been a pediatric cardiac nurse for over 20 years and a clinical nurse specialist for over 10 years. Dr. Lisanti received her PhD in 2014, and she's currently the nurse scientist and clinical nurse specialist at Children's Hospital of Philadelphia in the Cardiac Center and the Center for Pediatric Nursing Research and Evidence-Based Practice. Dr. Lisanti's program of research is focused on the application of family-centered developmental care practices to support neonates with complex congenital heart disease and their families. Thanks, Jo.
Thanks, Melissa. On my screen here.
Jo, while you're getting your slides up there, I'll remind the rest of the speakers to turn their microphones off, and that the links to these 4 recently published papers will be in the chat box, so you can just download the manuscripts.
Can everybody see that okay? Thank you very much to the planning committee for inviting me on behalf of my co-authors. I'm excited to present this paper to you about holding and mobility of pediatric patients with transthoracic intracardiac lines. I have no disclosures. I'm sure this esteemed audience does not need me to define transthoracic intracardiac lines, but in case we have some visitors on checking out this YouTube video that will be recorded, I will just let everyone know that these lines are vascular catheters placed directly into the heart in the operating room at the end of cardiac surgery. There are several advantages, particularly for the pediatric population. You can see them listed there. I'll highlight that, particularly in our center, I know our team finds that it's really helpful to spare blood vessels in patients with limited cardiac access, and we really like the benefit of the sterile placement in the OR. However, one of the major disadvantages, at least in our center, was that all patients had to remain on bed rest whenever they had these TICs or transthoracic intracardiac lines placed, and until they came out. So in 2014, our team really began to weigh the risk-benefit ratio of keeping patients in bed and limiting their mobility while having these TICs in line. We looked into the literature, and there was really a dearth of literature about nursing practice of caring for patients with intracardiac lines. And so we looked at some of the adult literature and found that early mobility in particular is well studied in adult critical care patients, and the benefits are evident. You can see the many improvements that they found in functional ability, reductions in hospital and ICU length of stay, and all of those negative things that we worry about in the ICU. But for me in particular, and I was happy to hear some of the discussion earlier about how it's so important for our specialty in pediatric critical care to begin to consider these human elements of care and how it impacts our culture and staff. One of the things I'm very passionate about is bringing that human element of care into our care of patients and their families, particularly those of neonates, and bringing that family-centered developmental care, that mother-baby care that is really a standard in neonatal intensive care units, and bringing them to the cardiac intensive care unit. It's becoming more and more recognized, but I was finding, we couldn't do it. We couldn't have parents hold their babies after cardiac surgery until those lines came out. And skin-to-skin holding in particular has been shown to have many benefits for hospitalized infants, and there's growing data in cardiac babies that this can reduce their stress and promote their comfort. So we really wanted to look at ways that we could get these patients out of bed. The other interesting thing is that both the early mobility literature as well as the developmental care literature both identified similar barriers to holding and mobility of critically ill patients. First, of course, staff concerned over patient acuity, risk of dislodgement, catheters, and other risk of dislodgement of those catheters or other medical devices. These were cited across the literature. And then there were other papers that talked about lack of local guidelines. And so we really thought, gosh, maybe we could address this barrier of not having local guidelines by creating our own. So the aim of this project was to determine the feasibility of safely mobilizing pediatric patients out of bed with TICs in our PCICU. Once we established feasibility, our secondary aim was to increase the amount of days that patients were out of bed with TICs. We used an iterative process and a quality improvement process. Without belaboring the whole entire process, if there's questions, just for sake of time, I'm just going to give a high-level overview. But really, I think the key here was having an interprofessional team. We had members from surgery, from cardiac critical care, bedside nurses, and advanced practice nurses that really worked together to troubleshoot, to trial different products to see which securement and dressing products together would work the best. We had a very, we had a limited trial with 6 patients where we tested what we thought would be the best way to do this. And it went very well. We had strict oversight with our clinical nurse specialist and the interprofessional team. And so we finally then rolled this out unit-wide. After we did that, we of course did prospective safety data collection, and then after a couple years did a retrospective review, which I will present to you. So our timeline was that we'd had a formal go live in July of 2015 with our new standards and procedures that we had created. Then in August of 2018, we extracted data to look at activity and positioning documentation to see if we had made a difference. And then in fall of 2018, we performed data analysis. So before I go through all of our results, I'll show you what we came up with. And we really did have, with our sim baby and all the different dressings, we were doing almost like arts and crafts, it felt like, for a while until we got this right. So you can see this infant has a intracardiac line with sutures intact at the insertion site. And then this infant has a Sorbaview dressing covering the intracardiac line. That's of course done under sterile procedures. And then distal to that dressing, you'll see a Duoderm hydrocolloid dressing. And the intracardiac line is coiled once with tegaderm that's placed on top. And we are careful to make every effort to not have that tegaderm overlay the Duoderm onto the skin so that we're minimizing any skin irritation. Finally, a grip lock securement device is placed distal to that to provide additional securement. Here are the holding guidelines that we had in place. They were holding and mobility guidelines in our cardiac intensive care. And you can see right here that our transthoracic intracardiac lines, they had lived under this must remain in bed column, and we moved it over here to requires discussion with a PCICU physician. And then we had additional guidelines that we developed on how to move this patient. Without going through every step, I think the highlights here are, it was almost like a safety checklist, right? So we wanted to make sure that prior to moving any patient out of bed with a TIC, we're confirming with the surgical team, with the PCICU attending, that the patient could advance their mobility. We're confirming placement on X-ray. We're making sure orders are in place, that this patient has an activity order that's correlates with the activity we were going to plan to do with that patient. And just making sure that, of course, the dressing and securement and all of that is in place prior to transfer. We do, as a part of our policy, ask that we have 2 or more healthcare providers to assist with the transfer. That way, one individual is looking at those lines and making sure that they're staying secure, while the other can focus on the patient and the movement. So we pulled data 2 fiscal years pre-implementation and 3 fiscal years post-implementation. I'm going to show you some descriptive statistics of our demographic data, and then how we organize these data is nurses have 2 rows. I think some people mentioned they were using Epic, so there may be similarities here across institutions, but the way we have documentation is there's a positioning row and an activity row. Both of those rows captured documentation that could be considered bed rest documentation, as well as out of bed documentation. So we recategorized all of that activity and positioning data across those 5 fiscal years to bed rest and out of bed documentation. We then used the Cochrane-Armitage trend test to determine whether differences in patterns of out-of-bed documentation changed over time. We also looked at the percent of patient days that patients were documented out of bed, since there was a range. Some patients may only have intracardiac lines for a couple days. Sometimes they would have them for a few weeks. So to get at that, we would use that percent of patient days and use the Kruskal-Wallis test to determine whether patients experienced significantly more days out of bed after the new policies were implemented. So over the 5 fiscal years, there were over 2,700 pediatric patients that underwent cardiac surgery, and of those, about 50% were given TICs, or approximately 250 to 300 patients per year. You can see the age ranges in table 2 did not differ across years, and we did not have any differences of diagnoses across year. You can see we did have a wide range of diagnoses represented in our sample. Out of the 5 fiscal years, there were about 1,000 bed rest documentations for patients with TICs and 334 out of bed documentations. The Cochrane-Armitage test, you see those results in table 4, that revealed that out of bed documentation was significantly increased after the new policies and procedures were initiated. And table 5 shows the Kruskal-Wallis test that confirmed that patients had an increase in their percent of patient days that they were out of bed. We did some additional exploratory analysis to see whether these intracardiac line standards and procedures got patients out of bed earlier. And so you see the results here, and we did not, in fact, change that. So patients still got out of bed about a median of 3 days post-operative. And then this box plot shows you that proportion or percentage of patient days that patients were documented out of bed. And you can see while we still significantly increased the amount of patient days that patients did get out of bed, there were a wide range of outcomes. This box plot, the whiskers show the ranges, and then the top of those boxes show the 3rd quartile. And so there were a lot of patients that, in fact, 20%, most of the patients were documented out of bed less than 20% of their postoperative patient days. Although for some patients, you can see it was as high as 90%. So while we did show a significant improvements, the standards and procedures did not yield similar results for all patients. We only had 3 adverse events experienced of internal malposition of the transthoracic intracardiac lines after we implemented, and they occurred within 12 hours of mobilization. After close examination of these infants, we found that in all 3 cases, the securement had not been performed according to the guidelines. None of these patients had any other complications, so there were no adverse events for the patient for their outcomes for this. But there was also no dislodgement at the skin, and so we really couldn't identify any cause of internal malposition, and this is a known complication for patients even in bed rest. So this quality improvement initiative demonstrated that pediatric patients with TICs can be safely mobilized or held. The new standards and procedures did help staff members provide safe care to patients. We documented a total of 269 times that patients were able to get out of bed. So we were very excited about that. Significant improvements were noted in out-of-bed documentation over time, but there still remained a wide range of outcomes for individual patients. Project was certainly limited by its QI design, and it's conducted a single PCICU, limiting generalizability. And unfortunately, because we weren't examining adverse events prior to the rollout of our standards and procedures, we weren't able to report rates over time, and we were relying on self-report for those adverse events. Although we were looking very closely, so I don't believe that we missed any. So in conclusion, pediatric patients can be safely mobilized when you're using established dressing, securement, and mobilization guidelines. We do need more research to determine whether these guidelines can be adopted by other ICUs and integrated into early mobility protocols. We also need to look at patient outcomes of early mobility and developmental care in patients with indwelling intracardiac lines. Thank you.
Thank you very much, Jo. It was a very nice presentation, and congratulations for your nice work. And this is something that we should tell everybody and start to see if other units are able to do the same, because this is something that breaks a paradigm. We always thought that these patients should be on bed rest. So this is very nice what you did. Now, unfortunately, we won't have time for more questions, but please type your questions on the chat, on the Q&A box, and we are going to be able to answer them for you during the other presentations. And now I'm happy to introduce Lisa DiPietro. She's going to talk about central venous catheter utilization and complications in the pediatric cardiac ICU, a report from the PC4. Lisa is originally from Boston. Then she did her cardiac fellowship in Cincinnati, and nowadays she is assistant professor of clinical pediatrics in the division of critical care medicine, and attends in Vanderbilt University School of Medicine, and she attends in the pediatric cardiac ICU. Welcome, Lisa. Thank you very much for staying with us today.
Thank you so much for having me, and thank you all for listening. Let me just share my screen with you. So as already stated, I am going to talk about a recent paper that we published looking at central venous catheter utilization and complications in pediatric cardiac ICUs from the PC4 clinical registry.
Lisa, can you move a little closer to your mic, possibly?
Sure. Is this better?
A little bit, yeah.
Okay. Let me see. I have nothing to disclose. So a little bit of background on this subject. There are multiple single center studies that exist to describe CVC use in pediatric patients who are undergoing heart surgery. However, there's a lack of multi-centered data on complications associated with the CVC use in patients with critical cardiac disease. Therefore, our 2 aims for our study were to assess the current use of CVCs in a multi-institutional cohort of pediatric cardiac ICUs utilizing the PC4 clinical registry. And then we wanted to identify specific risk factors for central line associated thrombosis and central line associated bloodstream infection. For our methods, we looked at all hospitalizations submitted to the PC4 registry from October of 2013 to July of 2016 to identify patients with at least 1 CVC in place during their CICU encounters. For those of you who might not be familiar with the PC4, it is a quality improvement collaborative that collects data on all patients who are admitted to the CICU service of participating hospitals. At the time of our study, there were 23 centers participating in the PC4 clinical registry. We looked at patient and CVC characteristics as risk factors for the development of either a central line associated thrombus or CLABSI. A central line associated thrombus was defined according to the registry's criteria of those requiring systemic anticoagulation, and CLABSI was defined according to the Center for Disease Control guidelines prior to 2018 with their definition of CLABSI. Our CVC characteristics included catheter type and locations. We then looked at multiple variables and assessed those as risk factors, and I have some examples listed here, but you will see a complete list later on in my presentation. In terms of our statistical analysis, we looked at descriptive data, which were presented as frequency and median for categorical and continuous variables, and our univariate analysis of risk factors for each complication were performed. And then for those complications, or excuse me, risk factors with a p-value of less than 0.1 were included in our multivariable logistic regression model. So here I will now share the results from our study. This is our table 1 looking at demographics. You will note that overall, about 70% of the hospitalizations at least had one CVC present. There was a predominance of CVCs in our younger population of patients. When we looked at hospitalization type, not surprisingly, surgical hospitalizations had more CVCs, with about 88% of them having a CVC present. I would just like to comment that overall, CVCs were in situ for a median of 4 days, with an interquartile range of 2 to 10 days. This table here looks at the catheter location based on hospitalizations. Overall, the most common location for our central venous catheters were in the internal jugular vein, with 46% of those hospitalizations. When you look at medical hospitalizations, they most commonly had a CVC in an upper extremity, which was a PICC line. We then broke down our medical hospitalizations by medical condition category, but for the sake of time, I'm going to skip over that. In looking at our surgical hospitalizations, most of our surgical hospitalizations included a line in the internal jugular vein with 52%. One thing that was interesting to us to try to break out was looking at our single ventricle population. As most people are aware, we try to avoid placing lines in any upper extremity central veins, knowing that these patients are going to undergo multiple operations as they go down the single ventricle pathway. When you look at the Norwood population, you can see that if you look at those with an IJ and those with an upper extremity PICC, we can say that about 30% of our Norwoods had some sort of upper extremity line. When we move over to the Glenn Hemi-Fontan group, again, focusing on the internal jugular region and upper extremity, about 50% of these patients had some sort of upper extremity line. And then when you get up to the Fontan population, again, just looking at the internal jugular and upper extremity PICC region, almost 70% of these patients have some sort of upper extremity line. This table looks at the type of catheters and their location. I'd just like to point out that in our PICC lines, most of them were in the upper extremity, with 76% of them occurring there. And then when we looked at CVC percutaneous lines, those mostly were in the internal jugular vein. Now moving on to the complications. In central line associated thrombosis, we had 248 hospitalizations. That was 2% overall, 1.8% in the medical group and 2.1% in the surgical group who had one of these thromboses. And these were diagnosed at a median of 7 days. When we looked at CLABSI, there was 127 hospitalizations, 1% overall, 1.4% medical and 1% surgical that had a CLABSI. And these were diagnosed later at a median of 15 days. This figure looks at the complications by location. The dark gray bars are the thromboses and the light gray bars are the CLABSIs. So we see that thromboses and CLABSIs occurred most commonly in the femoral region, followed by the upper extremity. I would like to draw your attention to this category of multiple. There are 21% of CLABSIs that were diagnosed when multiple catheters were in place, and therefore, due to the limitations of the registry, we were unable to define where these catheters were located. When you look at complications by line type, again, thromboses are in the dark gray and CLABSIs are in the light gray. We see that 51% of our thromboses occurred in CVC percutaneous lines. For CLABSIs, they most commonly occurred in PICC lines. And again, we have this category of 15% of CLABSIs occurring when a patient had multiple catheters in place and we could not assign a line type. This is table 4 from our paper, which is our univariate analysis of all the risk factors that we looked at for thrombosis and central line associated bloodstream infection. We looked at quite a few variables, including age, stat category, catheter days, whether or not a patient had multiple catheter in place, and risk factors prior to the diagnosis of either thrombosis or CLABSI. We then performed our multivariable analysis of risk factors, and all of the risk factors that you see on the left are significant, and I'd like to highlight a few. Younger age was more of a risk factor for both thrombosis and central line associated bloodstream infection, as evidenced by our odds ratio. Interestingly, mechanical circulatory support was a significant factor. However, it was protective against thrombosis. And we hypothesized that those patients receiving mechanical circulatory support are therefore anticoagulated and therefore likely to have less thromboses within their lines, although we do know that circuits can develop thromboses and clots and can sometimes clot off. We also saw that unplanned reintervention was a significant risk factor for thrombosis, but not for central line associated bloodstream infection. In conclusion, what we have found is that there is a difference in CVC utilization based on age and indication for hospitalization. The prevalence of venous thrombosis and CLABSI are low within our study population as compared to other published single center studies. And we found that the only modifiable predictor for these complications were total catheter days. Of course, there are limitations with any study that uses a clinical registry. First, we are restricted to the variables collected in the PC4 registry. We were only able to identify clinically significant thromboses, and those are those treated with anticoagulation. Also, for our CLABSIs, those that were diagnosed with multiple catheters in place prevented attribution to a specific catheter type or location, and therefore might underestimate the amount of CLABSIs occurring in each. Lastly, the ability to generalize data is potentially limited to centers similar to those within PC4. And I'd like to thank you all for your attention, and I'll take any questions.
Outstanding, Lisa. Thank you.
There
so
he
much.
is.
Thank you.
In the interest of time, we're going to move ahead, and hopefully we'll have some time at the end for additional questions. I'd like to take this time to introduce our next speaker. Next speaker is Ivie Esangbedo, who is a cardiac intensivist at Children's Medical Center in Dallas. Ivie has a special interest in resuscitation science and quality improvement. She's an assistant professor at UT Southwestern, and she'll be presenting her most recent work on risk factors for peri-intubation cardiac arrest in pediatric cardiac intensive care patients, a multi-center study. Ivie, thanks so much.
Thanks for the introduction. Can you hear me? No or yes?
It's a little hard to hear you.
Maybe a little closer to your mic.
Okay. So let me try sharing my screen. How do I do this? Can you see my screen?
Yes.
Sure can.
Yes, thanks.
Okay. Okay, thank you very much. So good afternoon and good evening, whatever your time zone may be. And thank you to the organizers of this amazing webinar series for inviting me to share my research. I have no financial disclosures. So I was asked to speak about our recent publication.
Ivie, it's still relatively quiet to hear your voice. I apologize. I don't know if you can go into your audio settings and turn your mic up, but it sounds somewhat muffled.
Okay.
Or maybe just coming closer to your computer.
Okay. Let me try that.
Or you can just yell at us. Those are the three options.
I'll try yelling. I'll try being a little louder. Is this better at all? I'm a little closer.
Yeah, that's better.
Okay. So endotracheal intubation is associated with hemodynamic compromise for a whole host of reasons. Firstly, you give medications that leads to bradycardia and hypotension, depending on what drug you choose and depending on your patient. And this may or may not be tolerated based on your patient's physiologic state. As you bag mask ventilate, you may run into issues with oxygenation and ventilation. This is very much dependent on your patient, but also on the skills of the provider who is bagging. These may lead to hypoxemia, hypocarbia, respiratory acidosis that all have profound effects on hemodynamics by way of bradycardia, contractility, and affecting PVR. Even in patients who are appropriately NPO, you may have gastric insufflation with bagging that leads to the potential for aspiration and further worsening of hypoxemia. And all of this is before you attempt to place the breathing tube. If your patient has difficult airway, you could have prolonged periods of hypoxemia that, especially if there's a poor pulmonary reserve, that lead to worsening potential hemodynamic complications as well. After your tube is in, you switch them to positive pressure ventilation, and so you have an increase in intrathoracic pressure that may lead to a decreased systemic venous return and cardiac output. And finally, just the overall procedure of intubation, moving the patient, positioning the patient, laryngoscopy, and placing the endotracheal tube could all lead to a sympathetic response by way of tachycardia and hypertension that in a patient with poor cardiovascular reserve would not be well tolerated and could lead to coronary ischemia, arrhythmias, and then increased afterload could decrease your cardiac output. So a few studies have looked at the effects of hemodynamic of endotracheal intubation in pediatric critically ill patients and the effects on hemodynamic adverse events. Almost all of these studies have been from the NERFA Kids database, so the National Emergency Airway Registry for kids. And most of them have shown a cardiac arrest rate that's between 1% and 3%, for, depending on the patient population. So for PICU patients, it's somewhere closer to 1.3% in this registry, and for cardiac patients, closer to 2.8%. And this registry has a lot of data from PICUs and mixed units and a few cardiac intensive care units. But the data for perintubation cardiac arrest in specialized cardiac ICUs had not been adequately described. So our aim was to describe the rate of perintubation cardiac arrest in critically ill pediatric patients who are cared for in a cardiac intensive care unit, and to describe the risk factors for perintubation cardiac arrest in this population. This was a multi-center retrospective cohort study involving 3 CICUs, and we studied patients who were critically ill, who had heart disease, and who were requiring endotracheal intubation. We collected data on the patients, the providers, and the procedure, and we compared the intubation events that resulted in arrest to those that did not result in arrest. We defined perintubation cardiac arrest as any cardiac arrest resulting in at least 60 seconds of chest compressions that occurred during or within 30 minutes of endotracheal intubation. So our inclusion criteria: patients who are less than or equal to 18 years of age with congenital or acquired heart disease and who were intubated within a CICU between January of 2015 and December of 2017. We excluded patients who were intubated outside of CICU, patients who were already on ECMO at the time of intubation, patients who were already in an arrest state at the time of intubation, patients who were being intubated for tube exchange, and all patients who have been intubated by an anesthesiologist for a scheduled elective procedure, even if that was done in the CICU. So our results, so first of all, it was 3 cardiac intensive care units. We had a total of 186 intubation events and 151 index cases. So 186 events in intubations in 151 patients. Just looking at the characteristics of the cohort, the median age was 3.1 months. The median weight was 4.3 kilograms. Almost 3/4 of the cohort was less than 12 months of age. And then also of note, about 24% of the cohort of the intubation events occurred in pre-Glenn single ventricle patients. We described the stat mortality category for the cardiac surgical patients in the group, and we defined that as anyone who had had their most recent surgery within 30 days prior to the intubation. And we did this just to show the wide range of acuity of the cohort. And you can see that the stat 4 and stat 5 cases were at least of the cardiac surgical group were more than half. And if you happen to pull up the full text of the paper, we also in the supplemental files describe the cardiac lesions for the non-surgical patients as well. So what did we find? The peri-intubation cardiac arrest rate was 7%, and the peri-intubation mortality was 1.6%. So there were 13 patients who arrested. More than half of them were able to achieve return of spontaneous circulation. 3 patients achieved return of circulation with ECMO, and 3 patients died. So the 3 patients who died were about 23% of the arrest group, but 1.6% of the entire cohort. So delving further into the arrest patients, most of them were bradycardia or bradycardia with pulselessness. There was no asystole. There was 1 patient who had VTAC and also had VFib. The median duration of CPR was 10 minutes. And as far as the etiology of cardiac arrest, it was mostly thought to be due to prolonged hypoxemia or worsened acidosis. There were a few cases of medication-induced bradycardia and hypotension and misplaced ET tubes. And there was 1 case each of aspiration and pneumothorax. So among the subgroup of patients with moderate or severe dysfunction of the systemic ventricle, the peri-intubation cardiac arrest rate was nearly 21%, and the peri-intubation mortality in this group was 6.9%. Among patients who were less than 30 days post-cardiac surgery, the arrest rate was 5%. So looking into the risk factors, we came up with a list of potential risk factors for cardiac arrest in patients getting intubated. And we wanted to compare the occurrence in the 2 groups, the arrest group and the non-arrest group. And I will say, first of all, that we didn't have enough pulmonary hypertension patients in the cohort to really comment about that as a risk factor. There were only 4 patients and none of them arrested. There was no statistically significant difference in single ventricle physiology, trisomy 21, or the number of post-operative days after cardiac surgery. We did find a significant difference in hypotension, the pre-intubation hypotension, with the arrest patients having a higher occurrence, so 60% of them had a decrease in the mean arterial pressure by more than 20% from their baseline prior to intubation. We also found statistically significant differences in systemic ventricular systolic function, lactate, and pH. So the arrest group was more likely to have moderate or severe dysfunction of the systemic ventricle, lactate more than 5, and pH less than 7.0. So looking at the provider and procedure characteristics, so I found it interesting that only 12% of the intubations in this cohort were done by an anesthesiologist. The ICU fellows still performed the plurality of intubations, about 38%. And there were actually a significant number of intubations that were done by nurse practitioners, about 14%. 11% of the intubations were done with video laryngoscopy, so a CMAC or gyroscope. 9% of the intubations had vasoactive infusion started specifically for the intubation. There was a significant difference in oxygen desaturation during intubation. And obviously that was higher in the arrest group. We didn't find a significant difference in the number of laryngoscopy attempts between the arrest group and the non-arrest group. There are other pediatric studies that have shown that you have a higher likelihood of cardiac arrest if the ET tube is not placed on the first attempt. I think there's one from Near for Kids, and then there's another one from the American Heart Association's Get With the Guidelines Registry. And I think probably the difference between our paper and those is the lungs in our cohort are probably less sick, more compliant, so that even if you don't get the tube in on the first attempt, they're more amenable to bag mask ventilation. But that's my theory. And then the atropine used was about 8.9%. Fluid, the administration of a fluid bolus for intubation occurred in 24%. And then as far as drug exposures, and this only refers to the exposures to these drugs and not combinations, the majority of patients received fentanyl. Ketamine use was in 16%, and etomidate use was in 8%. 2 patients received propofol. So we did find a higher rate of peri-intubation cardiac arrest in our cohort than in previously published data, and a significantly higher rate if there was systolic dysfunction of the systemic ventricle. We were unable to get reliable retrospective data on sedative drugs, the doses and the dosing intervals, which would have been very interesting as far as the aliquots and how frequently they were given. Duration and degree of hypoxemia between laryngoscopy attempts, and the degree of hypoxemia that's tolerated in cyanotic patients. So limitations, obviously, it has all the limitations of a retrospective study, specifically reliance on the past logging to capture the total number of events, I thought was a significant one. And then we're unable to do multivariable logistic regression just because of the small number of events in the arrest group. So in conclusion, peri-intubation cardiac arrest is obviously a significant cause of morbidity and mortality, and there are modifiable and non-modifiable risk factors. So some things to consider would be the development of a pre-intubation checklist at your institution, consulting an anesthesiologist for intubation, prepping for CPR since we have identified that some risk factors are non-modifiable, and then just making the environment more conducive for a safe intubation. Next steps, we actually have a 4th institution that has submitted data, and we're up to 277 patients in the cohort now, and we would welcome more centers. We're analyzing the subgroup with significant systolic dysfunction, and we plan to study atropine use in cardiac patients. I would love to acknowledge and express gratitude to the following people who are co-authors, who all helped with data collection, with recruiting more centers, and with statistics and reviewing the paper and at the time of submission for publication. And these are the 3 institutions that submitted data. Thank you.
Thank you, Ivie. That was amazing. We're right up against 4 o'clock, and I know people have a lot of 4 o'clock Eastern in the United States, I should say. And I know a lot of people have days filled with Zoom meetings and clinical at work. So what I'd like to do is encourage people to go to the Q&A, type your questions in there. Ivie, Lisa, Roberta, and Amy Jo, if you all could take a look and make sure that you make all those questions are answered so they can be recorded. I'd like to thank all the speakers, first of all, for a fabulous session. really amazing. We're sitting here 3 hours into this with 200 folks still watching and listening, which just speaks to the engagement and the level of the talks that were given. So thank you. I'd also like to take a minute to recognize the members of PCICS who really were the people who put this program together. Melissa and I, along with Jill, had the opportunity to represent the society, but this was really the work of 6 or 7 other people, including Melina Hanley, Lillian Sue, Lindsay Justice, Jean Connor, Jamie Pank, Michael Alice, who is one of the speakers, and Melina Hanley. So I just want to make sure we recognize them, say a big thank you on behalf of PCICS and CHA. They were the ones behind the scenes who did the work to put this wonderful program together. Sasha and Grace, thanks a bunch. This has been a ton of fun.
Thank you, guys.
Thanks. Thank you, Melissa. Gil, where is Gil?
Gil fell asleep.
So
No, Gil had another meeting he had to run to.
Hoping to see all of you very soon.
Only if you invite us to Sicily, Sasha.
We'll be there. We'll be there.
Thank you very much.
Thank you
see
so
you very
much.
soon.
Thank you. Thank you.
Stay well.
Bye. Bye.